Hello and welcome to the Allergy UK Masterclass webinar series. I'm your host for today, Margaret Kelman, and I'm a specialist nurse with Allergy UK. And today's lunchtime session is on chronic spontaneous urticaria. So this is a presentation that I'd like to share with you that showcases some of the work that we do at Allergy UK and the services that we offer to those whose lives are affected by allergy. And obviously, we know that Allergy UK is celebrating its 30th birthday this year, and this is a very special milestone for us. We are the leading UK-wide patient charity covering all aspects of allergic disease and manifestations, and this includes both IgE and non-IgE allergic conditions. And Allergy UK provides support and information for people living with allergic disease, and we work very closely with clinical specialists to ensure we deliver up-to-date and evidence-based information, support and advice. And Allergy UK, we aim to establish ourselves as the voice of people living with allergies so that we can work in collaboration with a range of stakeholders in order to take our vision forward. So our vision is that no one should die of allergy, and we have a mission for everyone in the UK to take allergy seriously, with a goal to empower, educate, research and influence. And through this, we deliver a wide range of activities and services for both healthcare professionals and the general public. So why do people need us? Well, there are over 2 million people living with allergic disease in the UK, and we know there is a huge demand for advice and support for people whose lives have been affected by allergy. And we have a huge role in raising awareness of allergic conditions in the UK and how allergies can affect day-to-day living. We're also, Allergy UK, we're very committed to advocating on behalf of the allergic community, and we've done this very recently. So here are some of the services that Allergy UK offer. We have a helpline, and this is the only support service in the UK that offers support on all aspects of allergic disease. And our helpline supports inquiries on allergy-related matters through our phone and web chat facilities. And it receives over 4,000 helpline calls and 3,000 webline chats by email to our helpline alone each year. The helpline is staffed by trained helpline advisors, supported by a team of clinical experts in allergy. And we can also call upon our in-house clinical experts, which is our health advisory board, which comprises of allergy clinical specialists from across the UK. We also use social media to reach people, and it's a great way to interact and engage with our audience. And we can do this via our Twitter, Facebook and Instagram accounts, and put out key messages to help support those living with allergy. Every month we have our new e-newsletter, which reaches over 46,000 people. We use the website, which has been kind of newly revamped, and have about 83,000 people visiting our website every month. And this includes our allergy house and weaning resources and lots of other resources. We also have an allergy alert service, and it's another service that we do offer. And if you have a food allergy, you can register for these alerts. So we are a former food standards agency, and these alerts provide advice on product recalls and possible contamination. And we can then forward this information to our members and help mitigate the risk of accidental exposure to a known food allergy. We also develop a lot of digital assets, and this includes the fact sheets, which have been designed to support people living with allergy. And they are a useful resource to download and hand out to patients during the clinic. So we've developed over 40 fact sheets that are available on the website, and we're still developing lots more in the background. The fact sheets are developed in-house by our clinical team, and then they're peer-reviewed by specialist clinicians all over the UK. And in Allergy UK, it's been certified as a provider of health and social care quality information by the information standards. We also take place in many surveys and research consultations on a regular basis, both for Allergy UK and for our other kind of external partners and stakeholders. And this helps us to better understand the allergic community and to enable people with allergies to have a voice or a say in their allergic care provision. And they are an excellent way to kind of explore the lived experience and quality of life and impact of those affected by allergic disease. We also work very closely with lots of our stakeholders. As always mentioned, this includes the public, clinical specialists, academics, external stakeholders, as well as government partners. And this is to make sure we are seen as a voice of the allergic community and can take forward actions that are important to our allergic community. And this way we can use our influence and bring about positive change for people with allergies. If you're not already, it'd be a good idea to visit the website for Allergy UK. We've got a lot of really useful information hosted on this website, including a special area dedicated to healthcare professionals. And on this, you'll find information about masterclasses that are available. Obviously, the fact sheets that you can download, but also Allergy Today, which is our publication for healthcare professionals, which has lots of information on topics that would be very relevant to clinical practice. So now I'd like to welcome you to the masterclass for today, which is chronic spontaneous urticaria. So today's lunchtime webinar will focus on chronic spontaneous urticaria. Each session is kind of about half an hour long. And there'll be a question and answer session, which will be held at the end of both sessions. So after both speakers have presented, we'll then have a question and answer session. And questions can be posted using Slido on our webpage or via the app with the event hashtag Allergy UK 0911. And the webinar will finish at 1:30. CPD points are available for attending each live session. Please complete the survey provided in your registrations email to claim your points. You will receive your CPD certificate approximately 6 weeks after the event. And the webinar will be made available on the healthcare professional section of the Allergy UK website after the event. Our speakers today are Dr. Clive Grattan. He is a consultant dermatologist at Guy and St Thomas's NHS Foundation Trust and has a special interest in cutaneous allergy and leads on specialised clinics in chronic urticaria and mastocytosis alongside clinics in general dermatology. I'd just like to say that unfortunately, Dr. Grattan is unable to be with us in person for this presentation due to his clinical commitments, but has very kindly recorded his talk, and I'm sure you will find this very informative. Dr. Grattan is, however, hoping to join us for the question and answer session at around 1:15. Our second speaker will be Polly Buchanan, who is a community dermatology nurse specialist in Fife. And I hope you will enjoy our session today.
I'm talking on chronic spontaneous urticaria. I want to explain what it is, its classification, clinical features, cause, some consequences, investigations, management, and prognosis. Firstly, what is chronic urticaria? Well, it's a disease or illness characterized by itchy wheals with or without angioedema for 6 weeks or more of continuous disease. And that means most days of the week. And the term chronic urticaria includes all patterns of urticaria, not just spontaneous disease. It may be episodic or recurrent, but this is not in the guidelines. The international consensus classification divides urticaria into spontaneous and inducible. And spontaneous may be acute or chronic, and there may be overlaps between spontaneous and inducible presentations. The inducible urticarias may be physical, like dermographism, delayed pressure, cold, heat, sun or fibratory angioedema, or other patterns like cholinergic, aquagenic, and contact. These pictures show wheals which are superficial and red and itchy. The redness may not be so apparent in pigmented skin. By contrast, angioedema is a deep swelling, and it's commonly of the lips, but could be anywhere, including the eyelids. And the skin is not redder than the natural skin color. It's important to remember that not all the urticase is urticaria. So this is an example of a patient with severe chronic spontaneous urticaria. And here we have another example of a patient looking similar, but this is actually urticarial vasculitis. Here the wheals are lasting longer. They burn rather than itch. A very important question is, how long do your wheals last? Because spontaneous wheals should come and go within hours, usually within a day. And often it's very difficult to tell because the overall eruption can last seemingly all the time. So this patient had a baro ring put around a spontaneous wheal in the evening, and by the following morning, it was gone. And this confirms the spontaneous nature of the urticaria, and other hives have come up. The question is whether children are the same as adults, and the answer is by and large, yes, with chronic spontaneous urticaria. It can happen in very young children to all ages in adulthood. And the main difference is dosing of medication. So I like this internet figure showing the baby with the mobile phone as they grow up, and then the adult with a mobile phone, illustrating the fact that urticaria can run right across the generations. Now, prevalence of urticaria is often quite hard to get good data on, but here's a European study in children looking at a 1-year prevalence of over 1% of chronic urticaria generally, and less than 1% of chronic spontaneous urticaria. Globally, studies in adults and children looking at the point prevalence, and that means the number of people with chronic urticaria at any one time. In Asia, it was over 1% of all ages, including children. And in Europe, it was less, but this was mainly an adult population. And in North America, it was 0.1% overall, taking all ages into account. But all of these indicate that chronic urticaria is a common problem. What's the cause? The main hypothesis is autoimmune or autoreactive. And two mechanisms are proposed: type 2b hypersensitivity, and these patients have a positive basophil histamine release assay, at 20 or 30% of all patients, or a positive autologous serum skin test, slightly more common, 30 to 40% of chronic spontaneous urticaria patients will show that, or type 1 hypersensitivity with IgE directed against autoantigens. Other proposed causes include infection, like Helicobacter, and there have been many publications on this, and other bacteria, parasites, and viruses have been reported, but they may be coincidental. Foods are often suspected, but food as a true cause of urticaria seems to be rare, and the studies often don't include oral food challenge as a proof of the causation. At the end of our consideration of cause, we have to say some patients do not get a satisfying explanation. They have idiopathic urticaria. And in the US in particular, chronic idiopathic urticaria is still often used as a term. Looking in more detail at autoimmune chronic spontaneous urticaria and the type 2b hypersensitivity, here we have IgG directed against IgE itself, bound to the mast cell or the basophil, or IgG directed against the high-affinity IgE receptor. By contrast, type 1 hypersensitivity is with IgE bound to the receptor, reacting against autoantigens within the body. Unlike allergens, which are external, like, say, cow's milk protein, this is autoallergy of IgE directed against autoantigens. In real life, the pathogenesis of chronic urticaria is complicated and often very difficult to explain, despite the sort of proposed reasons and mechanisms that I've explained. So this is a theoretical graph that helps to illustrate that. Now on the y-axis, I've put susceptibility to urticaria and a normal threshold for urticaria in health, which I think we all have. And the x-axis shows time in days. And when someone presents with chronic urticaria, they have a lower threshold for urticaria. And this is presumably due to enhanced mast cell releasability. And so maybe dietary pseudoallergens, which would not be important for most people, can be important in the context of lowered threshold. And then stress in the background will be running along, normally doesn't cause a problem. And then maybe infection, like a cold virus, can just take us closer to our threshold in the lowered situation of urticaria. And then maybe taking a non-steroidal drug in addition for the cold symptoms. And then put it all together. And then you have a huge stimulus crossing that arbitrary threshold, causing a severe outbreak of urticaria in the context of the infection and the NSAID, but also bumping along with the different factors playing in day to day. And this could explain why it's so difficult to predict what happens. And then as the urticaria gets better, then the threshold rises back to normal. And when it gets back to normal, then these things that are happening in the background are no longer important and relevant. Let's look at comorbidities in chronic spontaneous urticaria. There's atopy, and one study showed that 28% of children have asthma, allergic rhinitis, or atopic dermatitis, but this is probably less common in adults. We know that autoimmune disease is a comorbidity of chronic spontaneous urticaria, particularly thyroid autoimmunity, and some patients with systemic lupus and celiac disease. That is mainly in children. And psychiatric disorders have been identified as comorbidities in a high proportion. In this study, 70%, and you'll be hearing more about this in the next presentation. Chronic urticaria has consequences, societal costs, and this is an old study. Look at a small cohort of 50 adults in the USA with active chronic idiopathic urticaria, as they called it. The direct costs of laboratory, drugs, outpatient emergency and admissions were $1,725, whereas the indirect costs, lost earnings, travel to hospital, was $322. A bigger study, which was published more recently, was a retrospective case note review in over 600 patients. And here the annual direct cost per patient per year were estimated using the purchasing power parity dollar. And this was a study across Europe, and it was possible to compare the costs in different countries. So with this measurement, there were $907 in Italy, whereas almost $3,000 in France, showing difference in healthcare systems and difference in cost to society. But interestingly, the average indirect costs, and this is the patient-reported total work productivity loss over 4 weeks due to being at work, presenteeism, but not performing well, range from $500 up to over $1,000. And so, in summary, more than 20% of patients reported at least an hour per week of missed work, and the productivity impairment was 27%, really quite appreciable. Sometimes patients with urticaria can feel very ill, so more than skin deep. And this was a study in a tertiary center in the US, the number of systemic complaints that were reported by quite a large cohort of CSU patients. And you can see that about a third of them had no additional systemic complaints. They had wheals, they had angioedema, but they felt okay in themselves. but 28%, 8% of them had one systemic complaint. And as we go through the pie chart, 1% had 6 systemic complaints, feeling really poorly with the urticaria. So let's look at what these were. Joint pain or swelling was the commonest, headache, fatigue, flushing, wheeziness or breathlessness, gastrointestinal complaints, and palpitations. So we have to remember that our patients may be feeling very poorly with severe urticaria. Which investigations are useful? Well, blood tests should be considered for people who don't respond to standard doses of H1 antihistamines. And they would include a blood count with markers of inflammation, ESR, C-reactive protein, and in specialized centers, the basophil histamine release assay for functional autoantibodies. Total IgE is important, and recent data suggests that patients with low IgE also have a lower IgA, and this may reflect increased autoimmunity. And in the future, maybe we'll be looking for IgA as well. It's important to do an extended profile if there are suspected comorbidities or an alternative diagnosis, such as autoinflammatory disease. Physical challenge tests can be done in patients with suspected comorbidity of an inducible physical urticaria, so that they identify what they can avoid and therefore have better control of their condition. Skin testing is not usually done in chronic spontaneous urticaria, although the autologous serum skin test, looking for evidence of autoreactivity, may be done in some centers. This is when the patient is skin tested intradermally with their own serum to look for an inflammatory wheal response. Skin prick tests or immunocap may be used if there's suspected allergy, such as alpha-gal or Pru-P3, but this mainly applies to episodic urticaria rather than chronic spontaneous disease, and there should be some history that leads you to suspect that the patient is reacting. Or indeed skin testing for anisarchis in areas of endemic anisakiasis. Lesion or skin biopsy is sometimes necessary. It's rare, but it is required if you suspect vasculitis, because that will define the condition. In the clinic, you can say to someone, how is your urticaria? And that is a very good starting point. But these days, it's important to use patient-related outcome measures. And the most widely used is the urticarial assessment score chart for wheals and itch. And it's on a daily basis a good measure of the severity by recording a score from 0 to 3 for the number of wheals, another score from 0 to 3 for itch, making a total daily maximum of 6 and a weekly maximum of 42. And this can help treatment decisions and also monitor response to treatment. In addition, I would like to use the Dermatology Life Quality Index to see the degree of impairment in quality of life due to the urticaria, and also the urticaria control test, which is more recently introduced, that looks back over the last month to see how well the urticaria is controlled with 4 simple questions. Turning to management, the international guideline published very recently has reduced the steps from 4 to 3. And the first step is antihistamines. The non-sedating H1 second generation antihistamines, starting with a standard dose and increasing, if necessary, up to 4-fold. And this can be given in community, but patients who don't respond are then referred up to secondary or tertiary care when omalizumab can be considered. Now, patients on omalizumab in the UK have to meet the NICE criteria of severity, and we don't have flexibility of dosing like in some other centers when the dose may be increased, or indeed the interval shortened for people who don't respond well to the standard licensed dose of 300 milligrams once a month. And then those people who who don't respond will be offered cyclosporin or maybe other drugs which are immunosuppressive. Now, this algorithm is based on evidence. And the problem with evidence is if you don't have enough evidence, it doesn't get into the algorithm. We need to know our antihistamines well because we want to choose wisely. And in the UK, we have quite a wide range of non-sedating second-generation antihistamines. And you'll see from this figure that the daily dose is different and the approved age for the antihistamine also differs. So, for instance, desloratadine is approved for chronic idiopathic urticaria down to a year and above, whereas the fexofenadine is approved for chronic idiopathic urticaria from 12 and above. Cetirizine and levocetirizine may cause sedation, particularly without dosing, and loratadine, desloratadine, mesalazine, and rapatadine are metabolized by the liver, and we have potential drug and food interactions. For instance, fexofenadine and belastin, reduction of absorption with grapefruit juice, whereas rapatadine with an increased absorption with grapefruit juice. And mesalazine, we have to bear in mind there's a potential interaction with ketoconazole and erythromycin, which may lead to prolongation of the QTC interval that could be risky. So moving on to omalizumab, I've already mentioned that the dose may be changed in different centres, but in the UK, we stay with 300 milligrams every month. This is a comparison of different studies in the real world. We're all familiar with the licensed studies that were published some years ago, but this is looking at what happens in real world practice. And you can see that on average, the weekly urticarial activity score, the UAS7, is reduced by 27, which is a really excellent reduction from baseline overall in these studies. And some show a better result, some show a less good result. And this just illustrates that omalizumab has been an effective treatment for many patients. There are some predictors of response to omalizumab in CSU, and one of the best is total IgE, so that above range baseline IgE predicts a complete response after 2 doses, and non-response is predicted by a lower baseline IgE and a ratio of week 4 IgE to baseline IgE. And this seems to be the strongest predictor of non-response. D-dimers are measured in some centers, and the higher baseline D-dimer reflects urticaria severity, but it doesn't predict a good response to omalizumab. Nevertheless, the level will fall as the patient responds to treatment. Clinical characteristics can be useful as well. So a positive autologous serum skin test is more frequently seen in slow responders, and this is the subgroup with autoimmune urticaria, and I'll show you another figure of this in a moment. And basophil characteristics show increase at baseline high affinity IgE receptor in fast responders, but that is not available in routine clinical practice. So here's more data on autoimmune urticaria, showing that it's less likely and slower to respond to omalizumab than non-autoimmune urticaria. So if we look at this line here with the open circles, these are the patients with positive basophil histamine release assay as good evidence for autoimmune urticaria. You can see with the doses of omalizumab in arrows that they're slower to respond and usually get there in the end, by comparison to the subgroup of patients who have a negative basophil assay, and they usually have a high IgE, and these are the quick responders who do well. Looking at immunosuppressive therapies, particularly cyclosporin, because this has now been in use for at least 30 years. The best study in its design was a randomized double-blind placebo-controlled study in patients with a positive autologous serum skin test published some years ago now, using cyclosporine at 4 milligram per kilogram, and that was given to non-responders for a further month. And there was a 66% overall response, very encouraging, and the complete response was more likely in patients who did have a positive basophil assay, whereas the autologous serum skin test response was not so predictive of effectiveness. The data in children is weaker. It's low-level evidence, but it may be effective. There was one retrospective study showing early complete response in all children treated for 2 to 17 months with a relapse in 30% after stopping. But this was published before omalizumab. And I think many people now would regard cyclosporine as the next step rather than the first step for treatment of antihistamine unresponsive urticaria based on the guidelines and the evidence. And also, of course, that cyclosporine is immunosuppressive, and there have to be concerns about prescribing it during the COVID pandemic. Now, there are many treatments that have been used for chronic spontaneous urticaria, and they're sort of listed in the guidelines published in 2018 under Table 9. And I've summarized them here because they can be useful. The problem is that the evidence for using them is very low in some cases or quite low in other cases. And therefore, increasingly, they're being sort of regarded as treatments that could be used if the high evidence treatments have failed. They include antidepressants, doxepin, H2 antihistamines. These days it would be famotidine rather than ranitidine, anticoagulants, immunosuppressives, methotrexate, mycophenolate. They've been used. Intravenous globulins have been used. Montelukast is still widely used and can be useful add-on treatment. And miscellaneous treatments including say vitamin D supplementation and phototherapy, and the sulfone group, dapsone and sulfasalazine, I think particularly useful in delayed pressure urticaria. But there is some recent evidence for these old drugs. Azathioprine was found to be not inferior to cyclosporine, so showing efficacy of the sort of cyclosporine that we saw in previous studies. Dapsone, retrospective review, concluded it was useful, well tolerated. Doxepin, reasonable, efficient, affordable when H1 antihistamines fail, and still used in the US particularly. Methotrexate, no better than placebo for CSU over 18 weeks, probably too short a period because it can be helpful. And thyroxine, one case when chronic spontaneous urticaria resolved with treatment of Hashimoto's thyroiditis, and vitamin D. Some studies have showed a lower level in CSU, and that supplements might increase or at least decrease disease activity. Lastly, looking ahead, because this is really where the future lies in new treatments, novel targets, and this figure summarizes some of the biologics that are currently in clinical development for CSU. We know about dupilumab for atopic eczema. There's been a lot of publication about ligelizumab, a next generation anti-IgE, and the clinical trials are well advanced here. And we also have benralizumab and mepolizumab, which have been used in the context of CSU. But I think the interesting ones are the inhibitory receptors, CD200R and Siglex8 on mast cells, and antibodies binding these targets may be useful in the treatment of CSU. And I'm also very interested in an antibody against KIT, because preliminary studies, as I understand, have shown reduced tryptase and also reduced numbers of mast cells, and it may be of wider relevance to mast cell disease than chronic spontaneous urticaria. Moving sort of anti-clockwise, there are these antibodies against TSLP, tezepelumab, which I understand there's a clinical trial running, and antibody against C5a abiralimab. And this I don't think is currently under clinical studies, but maybe in the future. And then other targets on the mast cell that are of interest. And I suspect that there will be research programs looking at these as well. So to conclude about the natural history of urticaria and remission and recurrence, let's look at what data is available. It's not very good, I'm afraid, but at least we have some. So one study looking at new onset urticaria, and that includes people with acute and chronic, because of course acute urticaria may continue to chronic disease. The remission rate was over 50% at 1 year and about 90% at 5 years. And this, I think, is probably a little bit optimistic for chronic urticaria, but it does include the acute patients. And then we have chronic urticaria in children. This was one publication indicating spontaneous resolution in 30% at 5 years, which sounds rather pessimistic to me. And another study looking for recurrence of chronic spontaneous urticaria after remission in 17% after 5 years. And I think this reflects what patients say, that they may have had previous episodes of CSU, and therefore when it goes into clinical remission, it doesn't mean that it will be gone forever. And finally, just to close, I'm using this figure, which is from a publication that is many years old, but still is true today, of the natural history of urticaria to get better. And you can see patients with wheals are going to get better over a period of time, maybe even 10 years, but about 50% will be better within 6 months to a year, whereas those presenting with angioedema without wheals will have a worse prognosis for recovery, and 50% will still have it a year or two later. And then those with wheals and angioedema, representing the more severe urticaria, will have a longer duration before they become better. So what we really need is treatments that not only suppress symptoms like we have now, but treatments that actually modify the natural history of the disease and even will prevent urticaria from happening again. This is the goal for the future. Thank you very much.
Hello, and I'm sure you'll thank Dr. Grattan for a very interesting presentation. It was a very comprehensive look at CSU, so chronic spontaneous urticaria, the symptoms, the cause, investigations, scoring systems that are available. I found it an excellent explanation of the multifactorial causes that are involved in the development of CSU, and also the treatment options that are available, and the new treatments that are in development for CSU. So all in all, I think a very, very comprehensive presentation. Obviously, if you've got any questions relating to the information that's in this presentation, then please remember to put your questions via Slido with the event hashtag Allergy UK 0911. Okay, and our next speaker will be Polly Buchanan. She's a community dermatology specialist nurse, currently working in NHS Fife in Scotland. She was appointed as UK's first nurse consultant in dermatology nursing in 2000 and is a Queen's nurse as well. And Polly also has a very big interest in psychosocial aspects of allergic disease in skin, and will now present on our next presentation. Unfortunately, Polly has been held up at work, so we'll now play her presentation pre-record. Thank you.
My name's Polly Buchanan. I'm a community dermatology nurse practitioner with NHS Fife and a Queen's nurse. I'm also chair of the Scottish Dermatological Society. In this session, I would like to talk about the psychological impact of cutaneous spontaneous urticaria. So living with urticaria Traditionally, we use a very medical approach, but also much more so nowadays, we want to incorporate the psychosocial approach to our care. Now, before we start getting into that in any great detail, I just want to take you through a little bit of theory to be able to lay the sort of the foundation from what I'm coming from. So thinking about having an illness threat, anybody, yourself, think about yourself or somebody in the family, and think about any illness threat, whether it be the common cold, something more serious, or chronic spontaneous urticaria. The first thing that we do in our heads is to say, what is it? You know, is it curable? That's the next thing we say. And then we go on to think, how is this going to affect me? How long is this going to affect me again, as far as timeline goes? And then, can I fix this? So really, we're trying to give whatever health threat that we are facing an identity by asking what it is. We're trying to find a cause. What caused this? Is it curable? How is it going to affect me? What are the consequences of this condition? How long is it going to affect me? Is this a timeline? Is this short term, long term, or is this a lifelong condition? And the cure and control. How much control do I have over this? Can I help myself cure it? Now, this all comes from Leventhal's common sense theory. And you know, what we're really doing here is we're trying to understand the condition. So using chronic spontaneous urticaria as an example, understanding that condition, we will try and answer all of those 5 questions, which means we are thinking about the idea of it all. We're trying to cognitively work our way through those 5 questions. We're also going to have an emotional response, and that will involve our feelings. And then following that, we are going to come up with some coping behaviours, coping feelings and coping thoughts. Now, all those things affect whether our coping strategies are going to be effective or non-effective. And this all really relates to Leventhal's common sense theory of self-regulation. And this is a diagrammatic or a flow chart of how this works. So say we have an illness threat. So first of all, we would do this cognitive representation and try and find the cause, the consequences, the cure and control, give it an identity, and try and give it a timeline. At the same time, once we're working through that cognitively, we're having an emotional representation. And both of those, both the cognitive and the emotional representations, will elicit certain coping strategies. Now, how we cope then will affect the illness outcomes. It will affect how we cope in appraisal. When we think back and say, did that work? Did that coping strategy work? Did it work for me? And we do that whether we're thinking our way through this problem during our thoughts, we understand the condition, we understand what we can do about it, but then also the same process happens when I'm dealing with it emotionally. Am I fearful of this condition? Is it making me incredibly anxious? When I'm coping with my anxiety associated with this condition, how did I do? How did I cope? Were my coping strategies effective? And again, that will affect how I will cope emotionally in the future. Now, this happens all the time. And I think that this theory really sits well with how we cope with long-term illness. And that's really the basis of where I'm coming from when I'm looking at the psychosocial impact of a long-term skin condition. And in this case, it's CSU. So coping with urticaria. Another simplified representation here is that, yes, we have our thoughts and that will generate our feelings. Now, in there somewhere, those come together and we will generate our coping skills. Now, most of the time, our coping skills reflect back on how we coped in the past with other illness threats or other stressors, in fact, and that will influence our behaviour. So the emotional responses that we have could be, and have been reported by patients with urticaria, low mood. I feel very frustrated at this condition. I'm embarrassed. The uncertainty of it all, I don't know when it's coming back. I don't know what the triggers are. I feel worried. I feel anxiety. A lot of anxiety is often expressed. Sometimes even anger, fear maybe, and sadness that it's affecting my life so badly. Maybe even relief, when you get relief from that itch, relief from the when the condition resolves, and then perhaps even joy. Joy when we've found something suitable to be able to help us cope, whether it be medical or otherwise. Lots of emotional responses. One of the things that have been reported throughout the literature is that stress and CSU are inextricably linked. We know that. We know that with other skin conditions, chronic skin conditions. And the things that are reported most frequently that causes this stress is the incessant itch. CSU also affects sleep, and common sleep disorders, broken sleep, deprived sleep, affecting how we function the next day. It can affect appearance and affects our behaviours. It certainly affects quality of life in patients who suffer with urticaria. And also disease activity, disease severity. And that all can lead to anxiety, which is often expressed, and long-term anxiety can lead to depression. And then also there have been reports of drug dependence where we're constantly trying to manage this condition with drugs and then becoming dependent on them. So lots and lots of stressors associated with CSU. So what's the first thing that patients do, or people who are living with CSU do? Well, they want to seek support, and that's the first thing that we would be involved in probably, is helping patients in signposting. They will very often come to nurse specialists, GPs, health visitors, maybe then go on to see health psychologists, clinical psychologists, even social workers. Then signposting them to other professionals. It may be that counsellors are required to be able to support the person, and the family even. You know, teachers, if that's necessary, financial advisors even, if there's been loss of earnings due to time off work. And for children in particular, we've got things like Childline and overall organisations like Respect Me. We also have to think very importantly about signposting to support groups, urticaria support groups, Allergy UK, also support groups within churches, mosques or synagogues, and then never ever forget the support that family and friends can offer. We also nowadays have the information technology. So Skin Support is an information service, and it's online, and it provides very good, high quality information on all skin conditions, of which CSU is included. It gives very good quality information. It does take a very much a psychosocial approach, and it offers guidance on things like mindfulness, relaxation, and visualizations for people. So, you know, do think about Skin Support UK, but also we've got Allergy UK, who are a very, very important and active support group for people who are suffering from allergies. So how do people cope with stressors? Think about how you cope with a stressor. How do we cope with stress? Well, certainly me being a nurse and stressed and everything else, I know very often it's humour. We make jokes about it. If anything is stressing me out, let's laugh about it, because, you know, laughter's the best medicine. We've heard about that. Other people love talking and sharing about their issues. Seeing a professional maybe. Another way of dealing with it is I'm not going to talk about it. I'm going to isolate myself. Get angry. Maybe bottle it up. Maybe exercise. Oh, and CSU exercise might trigger something. Then we can get some not such good coping strategies like drinking alcohol, smoking, ignoring it. Then ask Dr. Google. A wee bit unreliable sometimes, but Dr. Google is out there and we can't ignore that. We can daydream, we can relax, we can get lost in music. We're pretty positive if you're good at these sorts of things. And then, of course, we can join a group, which we've also mentioned. So lots and lots of different ways of how to help people cope with stressors. And that's what people living with CSU will be considering. How do I cope with this? Because a lot of the time we don't have a cure. We understand that it may well come back again. So the medical approach is well understood. We've got guidelines, we have a stepped up approach, and we have patient pathways, and that has been dealt with. So let's look at the psychosocial interventions that are available that you may want to consider in the future. Some of them are at level 2, some of them are at level 3 intervention, but let's just talk a little bit about it to be able to see what can we do to help? So it's a much more of a combined approach with the medical interventions. So any psychosocial intervention would be aimed to reduce stress. It would be aimed to change the understanding of the condition or the stressor, ultimately change behaviour, and maybe even, hopefully, improve outcomes. So we do have lots and lots of information out there about psychosocial interventions, and there are different levels of interventions. So individual, family, community, whether it be a small friendship, village community, a larger community, or society, they're all there at levels of intervention. In the health profession, we consider levels of intervention. Level 1 as being the individual, level 2 a generic nurse, community nurse, district nurse, and in community and in secondary care. Level 3 would be much more of a specialist intervention at dermatology level or allergy level. And level 4 would be where we've got psychologists, psychiatrists, super specialists at the medical level. So different levels of interventions that we have, but they're all there to help people cope with their condition. So what psychosocial interventions are out there? And I'll talk about some of these today briefly. Ultimately, these psychosocial interventions are looking at the stress management that's involved with living with CSU. First and foremost, communication has to underpin everything. Communication with the person who's living with the condition, communication with their carers, communication between us and with our teams. So that goes without saying. Good communication, giving time to people to be heard and listening to what they have to say. Information giving and education, definitely needed. Understand the condition. Then we can move on to something that we're using much more certainly in nursing, is a problem-solving approach, where we use problem-solving therapy, which I'll talk a little bit about later. Then the cognitive behavioural therapy, which is well known. Relaxation therapy, distraction therapy, mindfulness, family therapy, and hypnosis. Now, I won't be talking much about family therapy or hypnosis in this talk, but the rest is enough to be going on with within the remit of this session. So communication, as I mentioned before, communication is absolutely vital. And anybody who has done a motivational interviewing course and developed their motivational interviewing techniques will understand just how important it is to be able to let the patient or the person living with urticaria feel that we're listening to them. But first and foremost, we can advise the person to self-talk, talk to themselves, think positive, talk to themselves, make a plan, talk to others about their signs and symptoms and what's distressing them. We also need to understand that verbal communication is vital, but what happens if somebody's not really confident about disclosing verbally? It means that we have to pick up on the non-verbal communication. When somebody sits there and tells you that there's nothing wrong, I'm not itchy, I'm not scratching, and then they're rubbing and agitating the whole time in front of you, you know there's something going on. So certainly with motivational interviewing, you would concentrate an awful lot on listening. In the first instance, listen to the patient so that they're doing more than about 75% of the talking. Then from that, as a health professional, we would be then deciding to guide, to lead, or to follow in our interviewing techniques. Guide that patient towards the right information, guide that patient towards behavioural changes, or maybe even lead if they, definitely show them the options and what's going on. Or are we following? Is the person wanting to take a real role in moving forward themselves? Very often in motivational interviewing, we would be doing all three at any given time. It's just, we swap from one to the other. But never forget that certainly in dermatology, but in nursing per se, traditionally we were always the one that would say, do as I say and you will get better. That doesn't work anymore. I mean, we have to be able to involve the patients in decision making, what they want to do. That means we need to listen. Sometimes we need to follow, but also there's a lot of guiding and leading going on. So don't forget motivational interviewing technique as a psychosocial intervention. Information seeking and giving. Lots of people are either information seekers or information blockers. So go on the patient cues. Make sure that if they want to seek information, make sure they're sourcing the right information. Most people nowadays, before they've even seen me, they've already told me what Dr. Google says. And also they want to see the right healthcare professionals, which is absolutely fine. Send them to a specialist who really understands the condition that they're living with. They also want to speak to other people who understand what it's really like to live with CSU. That's where the group comes in, joining a group where people can be empathetic because they know what it feels like. Recognizing others who are struggling. Yeah, that's really important. And then sharing good news and information. That is all part of information seeking and giving. Tell the success stories, be positive. Don't always focus on the negative of we're never getting to the bottom of this. There is a way through. We'll be positive. So share the good information and share the good news from other people with your patients and clientele. That takes us on to the problem-solving therapy. It's part of motivational interviewing technique, where see the living with urticaria as the problem. What is the problem? Identify the problem, and usually we would follow the 5 steps in problem solving. So you would help the patient do this. Identify the problem. What is the problem with living with urticaria? And it's mostly, they'll say, it's the itch. I cannot cope with the itch at night, or I cannot cope with the scratching, or I cannot cope with the anxiety or the fear, the emotional response. So whatever problems they come up with, then it's get them to look at their options. What are the options out there? What can we do? What are the consequences of these options? Let's just talk through it. What if we did this? Plan A, plan B, and evaluate it all. Look at the consequences. What are the best solutions? And then try it out. There's no reason, if it doesn't work first time, try the next one. See if it's worked. Analyze it. and see if it's worked. If it's been successful, do it again. Now, I know this sounds very simple, but this is all part of that Levinthal's theory. We're assessing how we coped in the past. We're assessing how we looked at a problem, how we addressed it, whether it worked, and let's see if we can do it again. So much more established cognitive behavioural therapy intervention. And this is, we know this in dermatology for sure, because we've used it for many, many years. And this is where we understand that a certain behaviour is learned and it's experienced socially and historically. And I'm thinking about, in particular, the behaviour that's associated with scratching for this, in this case. Scratching and rubbing and causing skin trauma, increased anxiety. So this behaviour influences our thoughts. Now, anybody who suffered from spontaneous itch will know to scratch it is entirely pleasurable. And that's one of the reasons why we do scratch, because we get a good feeling. It's a nice feeling to scratch. And time again, patients are telling me, but I like that feeling of scratching. But they're causing untold damage to their skin in the long term. So we need to understand their thoughts and attitudes to why they're scratching and what this scratching behaviour is doing to their skin. We need to understand how our emotions influence the behaviour and understanding. You know, if we're living with the skin condition, get the patients to talk about it. But mostly our behaviours become habitual and we become completely unaware of it, especially over long term. And that is particularly relevant for scratching. They just don't know they're doing it and they're scratching. So cognitive behavioural therapy is there to try and reverse that habit. And it really is trying to reduce the unwanted behaviour, which is scratching the skin, and replace it with other behaviours. And most commonly, we tend to suggest patting, rubbing or pinching the skin. So there's certain prerequisites for habit reversal for scratching behaviours, and that is a certain understanding. So we do need to take time with the patient to get them to understand what the scratch itch cycle is, what the condition is, why they're itchy, and so that we know that, and that they know that we understand why they're scratching, this pleasure feeling, and also understand their motivation. If they're not motivated to be able to want to do something about their scratching behaviour, then they won't do it. So this is, again, let's see if we can get them into a positive motivation mode rather than, not doing this, can't do this. We just need to move forward. And then think about the method. How are you going to use this habit reversal technique to be able to reduce the scratching behaviour? And then after that, it's practice, practice, practice. So the steps in habit reversal are definitely a period of awareness training. So what I tend to do is, after the understanding the motivation and discussing the method, we give them awareness training of how and when they're scratching. So a clicker counter. So every time they have a scratching bout, they click the counter and they count. And they do this for about 1 or 2 weeks. And it completely focuses the mind as to when they're scratching. So they're clicking. And it's a period of scratching rather than individual scratching, because most people have a real good scratch until they're sore or it's painful or the itch has gone away. And they would count that up. And then from that, they record when the time and the frequency and the duration of the scratching, and they can look at to see if there's any given time during the day or any other stressor in their life or whatever it is. So you need this awareness training so that if you can find these trigger points or these trigger times, then you introduce the behavior modification, which would be rubbing, pinching, distraction, a squidgy ball, patting the skin, anything that they want to do that you've discussed to be able to use it instead of the scratching behaviour. The next most common stress buster, almost as we call it, is a relaxation techniques. And we've used these often in the world of dermatology. So progressive muscle relaxation exercises are very important, and that often distracts the patient from the itching in particular and scratching. The deep breathing exercises are often useful, and meditation. Now that meditation could be something simple as mindfulness for 3 minutes, or even spiritual meditation, which is much more deeper and longer term. Distraction therapy is very often used, especially when you've got spontaneous itch or long-term itch, because it can start it and commence it very quickly. Visualization's one that I use quite a lot with my patients, teach them how to visualize and remove themselves from the stressor. And we do that through a visualization technique called the figure of 8. Doodle pads are in vogue at the moment, where people can concentrate on doodle pads. I think if that was me, I think I might use the pencil and start scratching with my pencil, but I don't know. It's whatever suits whoever. Doodle pads have been a very good distraction therapy. Exercise, I've mentioned briefly before. Yes, that's a good one, as long as the exercise doesn't induce any further urticaria. And music's a very good one. Loud music through headphones, people can often get lost. So there's lots and lots of distraction therapies that we can utilize with patients. Talked a little bit about mindfulness. We see a lot of this in nursing. In fact, we're encouraged to do it ourselves, aren't we? And that's really being in the moment. And whether we use relaxation, visualization, or just focusing on ourselves. 3 minutes a day, 3 minutes for me, or maybe even 10 minutes for me, whatever you can afford or whatever the patient can afford. If they're trying to interrupt the scratching behavior, it has to be even 3 minutes may be enough to do that. Very often we can find these mindful apps you can download on your phone are very useful, and YouTube's another one. Certainly I use a lot of apps and YouTubes personally, as well as I show patients where they are. And it just means for any given time, you can suddenly stop and then refocus and be in the moment and say, I'm not going to let this stress me out. And one of the things that's come into my practice very recently has been something called capacitar techniques. Now, Capacitar International is an organization that's really focusing on healing ourselves and healing our world. It started off by Pat Kane, who did her PhD in capacitar techniques. And she really wanted to help people cope with the stress and the anxiety of extreme trauma. And that trauma would be something like national disasters, where floods, fires, war. And her Capacitar International is now global. I belong to Capacitar Scotland, and the techniques that they use really help people to deal with the anxiety associated with whatever they're living through at the moment. Now, they concentrated on major disaster areas like Haiti and Africa, Afghanistan, anywhere that they needed real help and support to the survivors. Where I've used it is I know and understand that my patients have a lot of stress and anxiety, and that can influence their skin condition, and it can we know that it influences CSU. We know that it can trigger. Once you start thinking about it, it can influence the severity. Other ways around is that if you get a flare of urticaria, that can suddenly shoot up the anxiety levels, and it's incredibly stressful. And I don't know how many times you've had somebody in your clinic where you suddenly think, this person is so anxious, I need to slow down. I need to stop. I need to be able to say, hey, hang on, it's okay. I'm not rushing you. We need to be able to calm down, because of the anxiety that they're feeling, the fear that this is never going away, the fear that this is the itch will never go away. And that's when there are three things that I've taken from Capacitar, and that are the head holds, the finger holds, and emotional freedom tapping. So head holds are very gentle. It's non-invasive apart from holding heads, and you can just literally hold somebody's head and it automatically has a calming effect. You can do shoulder holds. You can just have your hands at the side of the heads for a few minutes, but I particularly like to move on to a head hold where one hand is holding the frontal part of the head and the other is the occiput. Now, my left hand is really focusing on the cognitive aspect, and my right hand is the emotional aspect. Now, I'm not pressing hard, I'm just holding. And it is absolutely amazing how it calms the very anxious down, especially children. It works a treat with children, works a treat with teenagers. And I've taught mums how to do this on their young teenagers' heads. I've taught people to do it themselves. And it really just helps people calm down when they're feeling particularly anxious and stressed. Finger holds are another one that people can use. Now, you can see from this slide here, each finger represents a different emotion. So the thumb is grief, the forefinger is fear and panic, the middle finger is anger, anxiety is the ring finger along with worry, and then low self-esteem. So say, for example, anxiety and worry was a thing that was really affecting somebody living with CSU. I would teach them how to do a finger hold where you literally just hold that ring finger. It doesn't matter which hand, but you hold the ring finger. And that way it kind of channels the emotionals out through the meridians, through that hand, through the finger, to be able to help them reduce the stress. Now, anger is another one. Anger is the middle finger. So hold the middle finger until you're feeling calm enough to be able to think, I'm not so angry anymore. This works so well with some people that I've even heard children say, Daddy, Daddy, hold your middle finger, because it just calms everybody down. It's an alternative behavior to be able to help calm the anxiety and the stress. And emotional freedom tapping, a lot of psychologists, mainstream psychologists, are using this now. And this is where we, again, if somebody's feeling particularly anxious about the itch, the desire to scratch, you can, and the worry that's associated with it, you can again tap certain points on your skin to be able to help release that emotion. And psychologists are using it with people before they go flying, if they've got a fear of flying, as it were. And so you would start off tapping certain parts of the body, and then the temples. And it's about 9 taps. And then just under the eye. And then just below the nose. And then just below the chin. And then under the arms, just with your thumbs, just literally under your arms. And then the final one would be running your hand down the outside of your hand till you meet the crease, and you would tap there 9 times. And that's when you would say a mantra, which would be, I know I have this problem, but I am okay, and I believe in myself. And it just calms everybody down. So these are things that I have introduced into my practice, which is like East meeting West. It's a very much holistic approach to help people cope with whatever they're living with. And certainly they act as a distraction therapy. It's calming the emotional state. And I've had quite a bit of success with it. And more, these are the 3 capacitar techniques that I am introducing to my, well, that I've established in my clinic. I'm not just introducing it. So that's capacitar, and that's you can look that up. Just Google capacitar, and there are certain training courses that one can go on to be able to help you introduce that into your practice. And then finally, what I'd like to do is just run through 3 case studies, which are of patients who have chronic spontaneous urticaria, and literally see where the well, there will be certain things that were worthy of note when they came into my clinic, or what the outcome was, or where psychosocial intervention helped them. So the first case was a 29-year-old female who had chronic spontaneous urticaria for 9 months, and it was really quite severe. We'd gone through the stepped approach of antihistamines. We'd even gone up to H2 antagonists and anti-leukotrienes. And we were also went on to refer to secondary care for consideration of immunomodulants and biologics. So we also discussed low histamine diet and, low salicylic diet, and we asked her to do a flare diary, everything. We were really trying to help her cope. Now, during the time while she was waiting to go up to the secondary care, remember this is during the pandemic, so we didn't really know how and when things were going to be moving forward, is that we talked about mindfulness, relaxation, distraction, and habit reversal. And these are the 4 things that we brought to her to be able to help her cope with the itch during that time. And I'm pleased to say that as the months and the years have gone on, with this combined approach, both medical and self-help, she's helping herself, she's coping with her urticaria really well. Case 2 was a 68-year-old gentleman whose the biggest issue was with him was the itching, but more so the scratching. He loved the scratching. He said it gave him so much pleasure. And he said it stemmed back from childhood. When anything went wrong in childhood, he would just start to scratch because he got so much pleasure out of it. But when the urticaria flared, you'd end up bruised, and he had sort of hematomas and bruises all over his body because he was rubbing and scratching. Now he's 68, his skin's getting thinner and thinner. And we thought, oh, we need to help him, definitely need to help this chappie. So medical approach, definitely. Combined approach, yes. We did a psychosocial assessment and really went through nearly every aspect of his lifestyle to find out, what was affecting him, what was triggering his scratching, how it is affecting his urticaria. And what came up was a social thing that was most important for him. And he was the main carer for his very poorly wife. She was mobile, but she was very much an invalid, and she had a progressive disease which was incurable. So I introduced the habit reversal technique, and we did a 2 weeks awareness program. And during those 2 weeks, we discovered that he would be scratch free for about 3 days, and then he would start scratching, and he would do 347 or 400 scratches in a day. And then same thing the next day. And then everything would settle down again. The urticaria would settle down. And then when we looked at his diet, he would only be scratching when he was worried about his wife, when she wasn't doing well, or when she was getting admitted to a care home for respite, or when she fell. It was purely surrounded his wife. So that was the first thing. And then the next thing, we introduced this alternate behavior, which we practiced and practiced and practiced. And he managed to reduce his scratching. The frequency of bouts of urticaria reduced, and he became much more happier with himself and with his life as it was then. So that's another case study. And the final one, which is a lady I saw only about, maybe 3 weeks ago. She is a 73-year-old lady and has had CSU for many, many years. Lots of psychological stress and anxiety associated with that, as well as other things going on in life and family. The medical management was with high-dose antihistamine and short-term prednisolone, had been reviewed regularly by the dermatologist, who was trying a dose reduction at the moment from efexofenadine 180 milligrams from QDS to 3 times daily. And that was probably about 2 or 3 months ago. And then she came to me in clinic with recent flares of her urticaria. So again, I went through the psychosocial history and I discovered that she had been suffering from a lot of joint pain and arthritic-y type pain, and had upped her NSAIDs incredibly, and she was pill popping them daily. So, and this was the trigger, I assume. I still have to follow this lady up, but I did mention to her, I said, you do understand that ibuprofen and Nurofen can trigger your urticaria. And she said, what? Are they the same thing? I didn't think they were the same thing. So yeah, and this one really, really brought home to me is always go back and do a full psychosocial history. Look at what's happening in their lives. Ask about what medications they're taking over the counter, because it could be something as well known as, drug-induced urticaria that has been triggered over and top of our acute CSU, as it were. So, and she's booked for follow-up. And then again, if urticaria becomes a long-term problem for her, I will be introducing the psychosocial interventions. In the first thing, this is the thing about the psychosocial interventions, is I always try and do the medical side first. Let's get some sort of control medically, introduce the antihistamines, inform about the stepped up approach, and then during that time, start thinking about the psychosocial interventions and what they would quite like to understand, what they'd like to explore, and then take it from there. So it is definitely I don't hit them with it all at once. This is a long-term relationship I have with them. So, and that's, and that's just me. Maybe it is, I don't know, but I don't see my interactions with patients as being once or twice. I see it being long-term, and I'm there if they need me within the given boundaries, as it were. So that's the final case study. So the take-home messages really is chronic spontaneous urticaria can have a profound effect on the patient's quality of life. We know that. But the management of CSU requires a biopsychosocial approach. And the psychosocial interventions can help to reduce the stress experienced with CSU. And really importantly, these psychosocial interventions can be available to everyone. Thank you very much for listening.
Thank you very much to Polly Buchanan for a very, very interesting and practical approach to the management of CSU and psychosocial interventions. I've now got lots of questions to put to you. So the first one is to Dr. Grattan. And this is a question that's come in regarding omalizumab. So the question is, does urticaria recur after 3 months treatment with omalizumab? And what are the serious side effects and how can we minimize them?
Okay, 2 questions there. Omalizumab will control the symptoms of urticaria in many of our CSU patients, but unfortunately, it doesn't change the illness. So if the condition is ready to come back at 3 months after, say, 3 doses, then it will come back despite omalizumab. So the current plan is to give 6 months of treatment to those people who are eligible through the NHS according to the NICE guidance. So at 6 months, then everybody will stop, wait, and if the urticaria relapses at that point, then a further 6-month course can be given. So 3 months is a time period that is usually not something that I would stop omalizumab at. I would keep going for the full 6 months as long as someone has responded. But some will be better at the end of it because they've gone into natural remission, and others will need a further course. Now, the second question is about side effects. The one that must be discussed is of anaphylaxis. Anaphylaxis is a very severe reaction involving drop in blood pressure, maybe difficulty with breathing, and this is recognized as a rare adverse effect, but mainly in the asthma population. Fortunately, it seems to be very rare in chronic spontaneous urticaria. But because of this, the first 3 doses at least need to be given in a medical environment. Does that answer the question?
Yeah, thank you very much. So the next question is, what medications would you advise for pressure-induced urticaria? And the caller says that they've heard that antihistamines are not suitable in this case.
Mm-hmm. Pressure urticaria can accompany chronic spontaneous urticaria, and it is the difficult component to treat well, unfortunately. Antihistamines often don't work very well for it, but it may be useful to add montelukast. Short courses of rescue steroid can be useful, but it appears that the pressure component of this overlap with CSU often does very well with omalizumab. So if the overall urticaria activity is sufficient to fund the treatment, then you can expect an improvement in both the CSU and the pressure component of urticaria. Having said that, there is a very rare subgroup of people with delayed pressure urticaria as a primary physical urticaria who don't have much CSU. And this is indeed a difficult subgroup to treat. And in the past, I've often offered the sulfens like dapsone or sulfasalazine with the correct use of steroids, i.e. the least that someone needs to control the symptoms.
Thank you. The questions coming in at hashtag Allergy UK 0911. There's another question here. Obviously, you mentioned that reoccurrence can occur kind of in 17% of the population after 5 years, and about 30% of children. But are there any reasons for reoccurrence of CSU that you've found within your practice? Is this mainly due to kind of infections or stress, or are there other factors?
Well, it's such a great question because can we ever assume that CSU is finally totally in remission and will never come back? And I think my clinical experience suggests that there may be a group of people who are at risk of further episodes of it. Now, why? I don't know. Maybe there are genetic factors, but the environment does seem to matter. So people who get recurrent episodes may, for instance, develop it after a virus infection, or possibly other events like change of medication. But usually it comes as a great surprise when the condition relapses. So I don't know the answer, but great question.
Okay. On standard dose antihistamines, how long would you leave before updosing? So kind of, are you talking days or weeks before you would updose from kind of 1 antihistamine up to the maximum 4?
Well, we have increasing experience of using the second generation non-sedating antihistamines at higher than approved doses. And I would say that if one doesn't work within a week, I can see no problem of increasing to 2 really that quickly. But you wouldn't do it within a few days because it takes a while to establish a regular drug level. But if there's no response to updosing to 2-fold, then I'd probably wait at least another 2 weeks before having the final dose increment. So people might go 1 to 2, and with the support and help of their doctor who has prescribed the medication, there is an option of that further step. But I wouldn't make the intervals too long. I wouldn't say wait for a month every time. A week would be the minimum. 2 weeks is possibly a good interval before making that decision. And it is in the international guidelines as such.
Thank you. We've now got a question to Holly.
I'm going to, if I may, just say thank you very much for inviting me. And it's lovely to answer these questions. And Polly, great to hear you too. But I've got another clinic and I'm going to have to shut down because if I don't leave now, I'm going to be late. But thank you very much for inviting me.
And thank you very much for your very interesting talk and for your contribution to the questions. It's been
That's all right.
brilliant.
No problem.
Thank you. Bye. Hello, Polly.
Hi there.
So I've got a question here. The person saying there's interesting techniques that are available, but if we want to learn these techniques, how do we go about this? Are there any online courses available?
Do you mean, well, all of them are available online, either with YouTube. If it was Capacitar you were particularly thinking about, Capacitar International's got very good YouTube videos which teaches you all of the techniques. Also there's Capacitar England, who if you contact them on their website, they'll have local practitioners who would be able to do one-to-ones and educational sessions, that sort of thing. Similarly with relaxation, visualization, they're all available online.
Thank you. You mentioned a lot of really useful techniques. The person's asking is for itch. What techniques would you recommend? And that you've had the most success with? And it's like two-part question. So what's the most success you've had with a technique for itch? And is it different for adults and children, or have you used kind of a very different or same approach?
I use a combination of approaches depending on how urgent it is. For children, we have to be quick with distraction, quick with getting their mind away from scratching. So I tend to use a lot of distraction therapy, finger holds, head holds, and for adults, it can be a bit longer, like visualization. Visualization works really well with adults, whereas with children, it's usually very fast intervention with that one. But habit reversal works incredibly well with adults as well.
Thank you. There's a clinical question here. Would you recommend a hypoallergic diet as a modality to treat CSU, especially when no identified cause is found?
I tend to have a kind of discussion with the patients on that one and refer them back to their specialist. There's a lot online about low antihistamine diets and low salicylic acid diets, but I tend to say, look, if you are going to do any kind of dietary manipulation, you must speak to the specialist, who will bring in a dietitian at that time. So I tend not to be very specific on that. I just have a general chat with them, guide them in the right direction to the specialist.
Thank you. Oh, we've got compliments for you here. Saying a great talk with so much depth and explained so well.
Oh, thank you so much. It's an area that I'm absolutely fascinated in.
Thank you. And also, there's another clinical question. What is the likelihood of a flare-up of urticaria with angioedema progressing to an anaphylactic reaction?
I think the angioedema is certainly a warning sign. I always, never mind just the swollen lips or the swollen tongue, I always ask them about breathing difficulties and tightening of throats. Now that's a major red flag, in which case I would immediately move them on to make sure that they do have some sort of anaphylactic rescue treatment in hand. So it really depends on, and I mean, the angioedema is not that common, and it is rare to get the strictening throat, the tight throat, or the breathing difficulties. But always ask about it. If you're in any doubt at all, you make sure that they seek the medical attention and get the rescue remedies that they need.
Thank you. And thank you very much, Polly, for a very interesting talk. It was really quite something else. Thank you.
You're very welcome. Thank you very much for inviting me.
Thank you. And thank you to all our viewers out there. Thank you very much for all the questions you've put to our clinicians today. Just to let you aware that we do have another webinar for the end of this year on the 1st of December on allergic skin disease and atopic dermatitis, and including another chronic spontaneous urticaria, but this time in children. And registration is now open at www.allergyuk.org/masterclass.